started right away. And our goal is like, we're going to make this a like true sprint of a clinical reasoning case. We have Andrea scribing for us today, and then Hoi Ting, who's going to be killing it with the teaching points. So it's great to see you all here. Thanks so much for joining. And yeah, we'll go ahead and get started. Maddie, take us away.
All right. Hey, everyone. So this is a human DX case. So I'll be reading off of the app here. So because this is a sprint, I'm going to give maybe more data than usual for the aliquots. So this is a 72-year-old male presenting with difficulty swallowing. So in terms of the HPI, he presented to the ED for 4 to 5 days of worsening pain with swallowing and a decrease in the ability to take PO. He reports that over the past several days, he has had progressive nausea, non-bloody emesis when trying to eat. 6 months prior, he noted worsening dysphagia with solid foods. A softer diet helps, but in the past week has been having these symptoms with all food consistencies, including liquid. On review of systems, he's had a positive for unintentional weight loss. He vomits 3 to 4 times per day, but only with PO intake. Denies abdominal pain, hematemesis, diarrhea, constipation, melena, or hematochezia. Past medical history is significant for coronary artery disease, AFib, but not on anticoagulation, type 2 diabetes, hyperlipidemia, GERD, diverticular disease, hypothyroidism. He has a history of dysphagia and reports a prior dilation 2 years ago. He had planned for a repeat EGD, but this was delayed due to COVID. Do you want me to take you through the physical exam, Jack?
No, this is actually a fantastic place to start.
Okay.
I think we can make a ton of progress based off of what we have here so far. I see both Noah and Deborah mentioning some important points in the chat here, and then also an excellent question from Yaz. Yaz, maybe I can start with you. I see you mentioning about the possibility of halitosis here and bad breath. How is that modifying the way that you're thinking about this dysphagia, whether we find it or not?
Hi, I'm sorry. Maybe you will hear the sound because I'm trying to run away.
That's all. It's a party.
I'm in Panera, actually. The thing is, with halitosis, I thought about it because it's pain with swallowing, and he obviously before listening to the non-bloody emesis, made me think of Sencard diverticulum because this looks like high dysphagia, but then again, he has been having weight loss, so that's not very common on Sencard diverticulum, for all I know. But that was my first thought until we got to the weight loss part.
Yeah, excellent. I love it. I think it's such an important point there about the halitosis, like you're mentioning, and then I see some great points in the chat about how the prior dilations are potentially modifying things. And I think if we just take a step back and think about how we can approach this finding of dysphagia overall, there's the sort of primary branch point when we think about dysphagia is this oropharyngeal dysphagia or esophageal dysphagia? And there's a few ways that we can differentiate between that. One is through the history, right? We can ask the patient, where do you feel like food gets stuck? Oftentimes oropharyngeal dysphagia, we'll see patients or individuals will point to the sort of cervical area and the neck. Whereas for esophageal dysphagia, right, they may point more down lower in the chest. And so sometimes we can localize the symptoms just based off of where they're experienced. Other times though, right, we might find somewhere spot on in the middle, and that makes it a little bit harder, or there's not a clear location to where it feels like food is getting stuck. And in those cases, we can use some other potential clues. One of the most helpful clues that we have here in the history is the way this dysphagia has progressed. Right, so we see that it started off with solids and then liquids were okay, but now it's progressed to all foods. And that's helpful because if we double click on the esophageal dysphagia bucket, we can have esophageal obstruction versus issues with soft tissue contraction or soft tissue or esophageal motility. Motility problems will usually be dysphagia to solids and liquids together, right? Because things aren't coordinated with contraction. Whereas obstruction will usually progress from initially problems with solids to problems with liquids. And so the fact that we're seeing progression from solids to liquids here really helps to increase the probability of an obstructive process. And that obstruction could be from an intraluminal pathology, like esophageal cancer, as people mentioned, or an extraluminal pathology, right? Something within the thoracic cavity that's compressing the esophagus, whether that's a mediastinal mass, which could be something like lymph nodes, or something that is potentially near the diaphragm or in the lungs. And so already from what Maddie told us, right, we have we can prioritize the possibility of esophageal obstruction because of the way that this dysphagia has progressed. And what we can also do is think about what next steps we might want to take or what clues we might want to look for on the exam to help us decide which form of imaging. Because there's two ways that we can evaluate the hypothesis of esophageal obstruction. One is quick, but less sensitive, which is a CT scan of the chest. And one, it takes a little bit longer to sometimes get, but is much more specific of a test. And that would be something like an EGD. So we may end up getting both here, right? But already we can see that we're sort of localizing into the thoracic cavity and something that could be an obstructive process, whether it's an intraluminal obstruction like a mass or extraluminal compression of the esophagus. And as you all mentioned, right, the weight loss here in the background signals to us that there could be underlying systemic inflammation, which would prioritize malignancy when we think about esophageal or thoracic pathology, but is certainly not specific enough for us to say that there couldn't be a potential infectious process.
All right, great discussion so far. So I'll jump into some more data we have. So on physical exam vitals, the patient was afebrile, heart rate in the 80s, blood pressure 148/79, respiratory rate 20. In general, no acute distress and non-toxic appearing. For HEENT, dry mucous membranes, no oral lesions or plaques. Cardiovascular, regular without murmurs. Chest, clear without crackles. Abdomen, soft, non-tender. Mild epigastric tenderness on deep palpation. Unable to appreciate the liver edge. No pitting edema in the extremities. So for some labs, sodium 138, potassium 4.9, chloride 110, BUN 23, creatinine 0.8, blood glucose 102, white blood cell 8.9, hemoglobin 15.4, platelets 193. Total Billy was 1.1 with a direct of 0.22, ALT 33, AST 22, outphos 107. CT abdomen pelvis with contrast was done, which showed mild lower esophageal wall thickening with contrast in the lower thoracic esophagus. Otherwise was unremarkable. An EGD was performed, which showed moderate resistance encountered at the lower esophagus, but with steady pressure, pop sensation occurred with the advancement of the endoscope. No mass or fibrotic stricture noted. Dilation performed, but without improvement in symptoms. So I have two more pieces of data. Would you like me to give you those last two?
Yeah, sure.
Okay.
That sounds good.
So an esophagram was completed after the EGD, which showed severe esophageal dysmotility, mildly patulous esophagus, narrowing of the distal esophagus with a delayed opening of the lower esophageal sphincter. And then lastly, the last piece of data we have is manometry. So that showed normal lower esophageal sphincter resting pressure of 24, so that was normal, but elevated integrated relaxation pressure of 43. So it says here kind of indicating a failure to relax. with absent peristalsis, but noted significant pan-esophageal pressurization. And I will pause there.
All right. I love it. I love it. So I would say, in full transparency with the team, I'm very unfamiliar with the manometry data here. But I think exactly as Maddie summarized, right, we're seeing that there is a failure to relax. And Maddie, maybe correct me if I'm, or please do correct me if I'm wrong, but it sounds like some sort of discoordinated peristalsis with in terms of how they measured the manometry.
Exactly.
And
even says
so
with
I think
absent peristalsis. Yeah.
absent pair. Okay, so we're seeing clear problems here with motility, but then we're also seeing problems with the underlying finding of particularly at the distal lower esophageal sphincter, right, where there is this sort of thickening in the area as well. So it seems like there is diffuse soft tissue soft tissue muscle abnormalities, with the extra added finding here of some distal lower esophageal thickening and some big resistance to pressing things forward. So I think if I were to sort of ask myself, how can we possibly put this together? It's that there's some problem with the smooth muscle of the esophagus, and also maybe some mechanical problems in the distal lower esophagus. I'm certainly not familiar with what things can cause esophageal mucosa to pop. But if we just use analogic reasoning, right, what are things in the body that can become solid over time, right? If we see something that is usually soft and smooth and flowing that then becomes firm and can crack or pop when you try to push through it, to me that says that some sort of mucosal surface, whether that's on the luminal side or the outer side, has become hardened. And times that we see things harden in the body, there's usually some component of calcification there, right? If we think about our vessels become hard and hardened from atherosclerosis and calcification, we can also have, for example, extra osseous calcifications in a variety of different areas. And so, or we can see deposition of solid molecules within the mucosal surface, and then sometimes over time with inflammation and fibrosis and scar, those can also become firm and solid and calcified. So I think one hypothesis here is that this is the very, very rare finding of sort of extra osseous calcifications in the esophagus causing dysphagia. But there's a huge list of things that can ultimately calcify, whether that's things like granulomas that can calcify, and other potential sort of chronic low-level inflammatory diseases. What I'm struggling with is how to link the diffuse dysmotility to these focal findings here. It's possible that this is a process that's happening all throughout the esophagus, and we're seeing some of the calcifications that are happening within the lower portion of the esophagus only, because that may be like the most sinister part of the disease process. But I think that that's my best working hypothesis. There is some process that is causing an impact to the smooth muscle of the esophagus, that is primarily affecting the distal lower third of the esophagus. And then that crack that we're hearing is maybe reflective of there being some calcification somewhere within the esophageal mucosa. That is about as far as I can realistically take it there. So I will turn it over to you, Maddie, to undoubtedly teach us a lot about what is probably going to be a diagnosis that I may have never heard of before. So I'm very excited.
Yeah, all right, fantastic. So the final diagnosis here was alkalasia, and they have a lot of teaching points on it, which I can go through. So there's a little bit of teaching on like the series of tests they did in the workup. So it says here that EGD was first performed and should always be the first step in working up esophageal dysphagia. No strictures were found, but there was resistance in the lower esophagus with a pop sensation, suggesting a muscular obstruction. The patient initially had improved symptoms after the dilation, but it only lasted for 1 day. This led to further motor/propulsive dysphagia workup with esophagram and mammometry, which showed an elevated integrated relaxation pressure, which kind of indicates failure of lower esophageal sphincter relaxation, ultimately suggesting alkalasia. because there was evidence of esophageal pressurization, alkalasia type 2 diagnosis was made. And a little bit of epidemiology that on alkalasia. So it's a rare disease caused by loss of ganglion cells within the esophageal myenteric plexus, with a population incidence of 1 to 3 per 100,000, and typically presents between 25 to 60 years of age. So loss of inhibitory neurons leads to failed relaxation and propagation of peristalsis at the lower esophageal sphincter. Most patients report solid and liquid food dysphagia with regurgitation. Differential includes diffuse esophageal spasm, Chagas disease, and pseudoalkalasia, which is obstructing tumor. So I will pause there. Oh, it seems like Jack had to hop off. So we will, I guess, pass the mic to Hui-Ting to take us through the teaching points. Mike is yours.
Hi. Hi, everybody. Thank you, Maddie, for this wonderful case, and thank you for stepping in, actually. And oh my God, yes, this is a great case, and thank you, Jack, for discussing this, and everybody for participating, because I saw so many comments in the chat, which is great. So this is actually a very short teaching point, but here goes. So we start doing the approach to dysphagia. So Dr. Jack taught us how to do, there's a classification we can see maybe to localize the dysphagia, if it's oropharyngeal or esophageal dysphagia. So we can do it through history, localizing the area, but sometimes it's very difficult because it's not so easy to pinpoint exactly where's the dysphagia. And we also have to ask the progression of the dysphagia, which is very important to see if it's solid, or if it's liquid, or is something mixed. And that give us more clue of what type of dysphagia we are looking for. So when it comes to esophageal, we have the classification, we have obstruction, or we have a problem with motility. So when it comes to esophageal obstruction, the progression of the dysphagia is from solid to liquid. And the causes can be intraluminal pathology or extraluminal pathology, such as a mass compressing. And when it comes to esophageal motility, is when the dysphagia is both solid and liquid. And it's very important when it comes to the diagnosis. We can do CT chest for quick diagnosis, but the EGD is more specific. However, it just takes more time for the diagnosis. And we have this problem with the smooth muscle and plus a mechanical distal lower esophagus. So in this case, we think about maybe calcifications, a chronic inflammatory condition, or atherosclerosis. And with the final diagnosis, which is achalasia, we need to, for the diagnosis, the first thing we need to do is to do an EGD for the diagnosis. So yeah, this is a very short teaching point, but I hope you all enjoy the case, and I hope you have a nice rest of your day.
Awesome. Thank you so much, Hui-Ting, for taking us through all the teaching points from this rapid fire VMR.
Yeah.
All right, everyone, we will end there and hopefully see you tomorrow for another virtual morning report. Take care, everyone.